Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome, everybody, again to another episode of our show. Today, bringing you another really awesome guest involved in creating a better tomorrow. Today, we have the honor of being joined on the show by Dr. Doron Behar, who is CEO and founder of a really unique end-to-end genetic platform company known as Igentify that provides a suite of digital tools that's designed to scale the provision of various genomic medical services to more people worldwide, making these services accessible, actionable for clinicians as well as laboratories and, of course, patients. Dr. Behar received his dual degrees from the Technion Institute in Israel as a medical student. He has dual specialization in both internal medicine and critical care medicine from Rambam Medical Center in Haifa. Dr. Behar's research areas are quite broad and his interest across a range of evolutionary genomics, ancestry, phylogenetics, as well as translational genomics. He's been a leading author, a co-author of numerous research papers in all these areas. He's the former chief scientific officer of Gene by Gene, a really unique commercial genetic testing company. And again, his expertise and interests cover various aspects of mass genotyping, including regulation, privacy, genetic analyses, quality assurance, and much, much more as we get into this area of population genetics and consumer genetic testing. Wanted to have a lot to talk about. Dr. Doron Behar, thank you so much for taking time to come on the show.
Thank you, Ara. It's a real pleasure. And I'm looking forward for our conversation and to, educate and make our motivation, our vision and mission as widespread and as clear to everybody as we can.
Outstanding. And yeah, I mean, before, we get near what you're doing today, which is completely fascinating. I'd love to, start off at the beginning. And I always, I take a dive into our guests' sort of scientific background. And you are on two, entirely separate paths that ultimately will show how they come together. But on one hand, a large suite of publications on rare autosomal genetic disorders like familial tumoral calcinosis and C7 complement deficiency, and interesting connections between urinary tract infections and Crohn's disease. And while you're doing all that, you're also figuring out about our founding mothers of the Ashkenazi Jews via your PhD, genomic diversity of Near Eastern populations. Take us back. Tell us the early story here, because it's fascinating how these two things came together for you.
Yeah, so it is quite interesting, I must say. And it is, of course, a little bit of a fortune or luck being involved in this all the time. So I started as an internal medicine doctor, and then I made my way to critical care. And one can say that nothing can be as apart from this in medicine from the field of genetics. But then I was lucky enough, and I had in my hospital my mentor, Professor Karl Skoretsky, who was actually one of the founding fathers of the field of phylogenetics. And for me personally, it came up quite nicely together, because, if I look at what I'm taking photos of, where I'm traveling, then I was always fascinated about diversity in the nature world, diversity of different ethnicities, how people were moving around across the world. So it was always fascinating for me. And then I guess that these coincidences of having an opportunity to deal with genomics, which is certainly part of medicine, and trying to explore my other love, which is for, again, the diversity in the world and so forth, it came up really nicely. And I also was fortunate enough to have the right mentor in time. So that gave me an opportunity to do PhD in the field of population genetics. And falling completely in love with the field of genomics because of many various reasons which we can certainly discuss in this conversation. It took me into a very unique situation in which I understood that eventually, when we speak about precision medicine, when we speak about genomic medicine, when we speak about prevention medicine, we are actually speaking about the population genetics. How do we take it down to medical genetics in population? And actually, the best thing for us to do as healthcare providers is to prevent, right? That's the most important thing to do. And if you look actually at the most important advantage of using genomics is the ability to identify risk and to prevent diseases from happening, whether it is in the reproductive health time, whether it is for questions of oncogenetics or pharmacogenomics, which we can explain about all, of course. And these are all things that have combined my love for population genetics and my love for to do good medicine and to actually establish Igentify, which it is exactly, the name says exactly what the genome knows to do, to identify genetic variation that might be of importance to people in different stages throughout one's lifetime. So yes, indeed, it is quite unique for somebody who is in critical care to switch to genomics, but this is what happened.
And it's quite interesting again, and we'll get to Igentify in a minute. But again, as I swim through your publications in this area, as you get deep into this intersection of population genetics, diversity, and of course the detailed genomics that comes on the scene, you're sort of the worldwide traveler, right? You're looking at these APOL1 risk variants in Ethiopian populations and connections to nephropathy. You're looking at conditions like cystic fibrosis and different multi-ethnic societies. You're headed out all over the globe to study these really detailed connections. Talk a little bit about this period because we'll get to Igentify in a minute, but important learnings, anecdotes, other important stuff that came up during this period, because clearly this goes in sort of infinite directions based on the type of associations you made.
So I think that the very, very good school for genomics is population genetics, because a few things that you are learning while you start with very basic population genetics, and we really speak about the first period, which something very clear now can be explained to everybody quite easily. So we started with the Y chromosome, with the mitochondrial DNA, and then with the autosomes. So if we start with the Y chromosome so that everybody can immediately affiliate with the subject and everybody can become population geneticists immediately by themselves, is the fact that we have learned that, as we all know, that there is XX and there is XY, right? So males have XY. So that means that the Y chromosome of any individual, any male that is currently having a Y chromosome can only come from his parent and from his grandparent and so forth, because that is the only way that Y chromosome will be transmitted. And then we understood, and that will turn you immediately in population geneticists, then we understood that in many Western civilizations or communities, the surname often passed from father to son. So we have the father to son, and we also have the Y chromosome, which is passing father to son. So the surname and the Y chromosome tends to pass together. And then a trivial question will be, if two individuals have the same the same surname, why is it? Is it because of identity by state or by descent? What do we mean? If it is identity by descent, it means that they had a great father that they forgot about him, but he gave throughout the lines of the family growing, they gave the same surname to everybody. A different situation might be that two people were deciding to label their surname based on their occupation.
Mm-hmm.
And then they are identical, but it is by state, it is not by descent. And how can we make the difference between the both of them? By looking at the Y chromosome. So basically, if two individuals have the same surname and they share the same Y chromosome, that means that they are related in somewhere across their paternal line. And that was really the beginning of this. But the beauty of this was that through this, you could understand that indeed certain Y chromosome profiles are more frequent in different places in the world.
Yep.
And you can also understand from this that mutations, or as we call them today, variants, are not just happening. They have hierarchy because there's the baseline and then mutations are occurring on top of it. And I always love to give an example of a book that was printed and sold out, and then there was another print of the book, but there was one mistake in one page somewhere. One letter was changed, but now we have two types of variants around, two types of books. And then if the third one is being now printed on based on the version 2, then it must have the mutation of version 2, so there is hierarchy. And the Y chromosome, and then later on the mitochondrial DNA, which represent our maternal ancestry lineage, then that is gave very good understanding of how genomics have a lot of binary processes and digital processes inside the understanding of it, which make it very clear that variants are being built one on the hierarchy of the other, and many times have affiliation to a certain geographic region in the world, because this is where the mutation have occurred, or this is where people have migrated to. And then when you combine the Y chromosome and mitochondrial DNA, for example, and again, the Y chromosome is tracing the father of father of father of father, and the mitochondrial DNA, mother of mother of mother of mother. So there are many ancestors in between that we don't know about. But when you then combine both of them together, and you can actually see that certain hierarchy was created both on the Y chromosome and the mitochondrial DNA, and you can now start showing how the migration of Homo sapiens was throughout the world, and how we started probably in East Africa, and how we made it all the way to the Americas. And you can actually show that as you progress, you have more recent lineages, and you have less lineages, because only few made it all the way. Yeah. And then when you combine both of them, then you can see that this is a great understanding that indeed our genome hold the relic of our past.
Yep.
And that is very important.
Absolutely.
And then now we wanted to learn more about all our other ancestors, not the ones that are in the direct lineages. And then it was extended to the autosomes. And then the autosomes are actually giving what many people are referring to today as a general estimate of the ancestries that are making each of us now. So that's something that a lot of ancestry companies were allowing people to do it. I was involved, of course, with the Gene by Gene, as you have mentioned, and naturally the Genographic Project, which was a very nice project shared between National Geographic and the general public, allowing to educate and to learn about it more. And then we had all of this is actually leading us now to the medical field.
Yep.
And why is it so important and so beautiful? You have mentioned the end-stage kidney disease story. And a lot of it started by understanding that kidney failure or end-stage kidney disease is more frequent in different ethnicities. So it is more frequent about individuals who are Black, and then, for example, about individuals, then as compared to people who are from all the rest of the world, basically. So that means that if you can look to the ancestry component of this and try to see what within this ancestry component might lead you to the disease, then that is giving you now a very strong tool to actually use methods, they call that mixture and so forth. I don't want to go into the details, but basically it allowed to affiliate that a certain variant in a certain diversity is associated with this phenotype.
Mm-hmm.
That was a beautiful example of the past.
Yep.
And naturally a lot was learned about it. And why are we doing this? Because of course, first we want to identify risk, but also you want to try and develop drugs maybe that will
Yep.
be using the genetic pathway to do it.
Yep.
Equally important, and you were mentioning the cystic fibrosis, for example, disease,
Mm-hmm.
then once you want to screen individual at the preconception or prenatal stage for a risk with a kid of cystic fibrosis, then remember that we started preconception screening 40 years ago. And we couldn't then screen all the genome for everybody. Also today, we have a hard time doing this, but we couldn't do it. And then you had to understand what are the variants that are putting this particular population at risk. So the variants, for example, among Ashkenazi Jews might be different from the variants among Finnish population.
Yep.
And you want to target your resources so that you can attract, you can capture as much of the risk as you can using the knowledge of which variants are affecting this population. And why is it the case? It is the case, again, and it is a direct connection to our population genetic studies, because eventually you understand that population do differ one from each other, but you can look at it phenotypically, and naturally it is also being visible with the genome.
Yep.
Which means now that basically Ashkenazi Jews, as an example, as any other population, you mentioned them, they simply, it was an inbred population. All populations were inbred. This is how diversity was established in many ways. And of course, then admixture between populations. So there's a lot of processes in the field, but no doubt one of them is inbred. So it makes sense that more mutations that are causing this given disease will be clustered in the same population.
Sure.
So we used it, and then came again the same situation previously. A few years ago, it's a recent development relatively, drugs that can help cystic fibrosis patients were developed, and they are mutation specific, which means if one's cystic fibrosis is because of this mutation, you can give this drug. And that was clearly a great promise for the patients. And then we, for example, in this particular study, we have actually learned all the variation of the cystic fibrosis mutations, so we can tailor the right drug to each individual.
Yep.
And then it goes on and on and on. And this is how, and more importantly now, that in the past, genetics was something which was much more affiliated to the field of pediatricians, pediatric
Right.
medicine, but now as genetics went genomics, we see it in every field of medicine. Yep. We see it in oncology, in cardiology, in pharmacogenomics, in neurology, in ophthalmology, with the ENT doctor, everyone so it became genomics. And now it is really very important to educate both the healthcare provider and the patients for the benefits that they might harness from doing a genetic test. So I would say that for me, population genetics is certainly connected to medical genetics. But once again, when I think about genetics, I'm thinking about how to deliver as much result as possible to the healthy population, not the sick population, to the healthy population, so that they can identify risk and take actionable measure against it. And I'm sure we're going to come back to this in our conversation.
Yep. Yeah, no, it's we'll go to further to it now because it's at October 2020, Genetics in Medicine, you publish the 7-year experience as teaching clinicians practical genomic medicine, 7 years experience in tertiary care center, where you're basically, talking about what you were just saying, we have these increasingly complex genetic technologies and clinical practice in all areas of clinical practice, but we need to keep up genomic literacy and proficiency for all medical professionals. In here is sort of the thesis, sort of why you set up Igentify, but talk about this paper and then introduce us, please, to the founding of which happened a couple of years before.
So I was fortunate to be part of the list of authors there. Naturally, this entire attempt, or a successful attempt to teach medical doctors who are already 20, 30 years in their medical career. Yes, these are not students. It's the understanding of colleagues of mine that there is a demand from the field to start understanding more and more and more about what does genetics is about, how can they utilize it, or at least, Ira, to ask, when should we ask for an advice of a medical geneticist?
Yeah.
So it really came from the field, and the people were asking for such an opportunity to learn about all the advantages. Now you can clearly have this within the field of OB-GYN, the genetic testings that we are now offering during pregnancies. Of course, they wanted to understand more and more and better about it. And then it also affects now, if you are in a cardiology setup and there's a patient with an arrhythmia or with a cardiomyopathy, then you might be able to identify a genetic risk that did it, a genetic disease, and you can maybe prevent it from the next generation and so forth. So it really came from the field. And I can tell you that what is not written in this paper is that it was very successful. The queue to be in such a course were quite amazing. And I can tell you also that this particular program was then, other hospitals did also similar programs, because indeed, genomics now is in every field of our life. And it's about learning the vocabulary. It's about learning that genomics have advantages, might have disadvantages, discussing it, making it the public domain, making the understanding of when it is useful to do genome studies, what is the relatedness to this, and privacy, confidentiality. The population had to know more and more about it, so as the healthcare provider, so that we can benefit the individual. So I would say that was a very great example of a demand from the field that was proven to be very successful, and was indeed one of the ways, one of the corridors we are taking on the way to explain genomics to everybody.
And so this leads, well, as again, the thesis for Igentify is in there, but introduce us to the company. Obviously, you founded the company back, I believe it was 2016, and explain what the core digital genetic assistant is all about, and then we'll get into the different sort of themes that the digital assistant can be involved in terms of the screening and pharmacogenomics and so forth.
Absolutely. So as a medical geneticist, it was clear that the first bottleneck 20 years ago was the mere ability to create genomic data. we didn't have the ability to do genome, right? But the technology companies and have been quite fast to eliminate this barrier. And now we know that we can get to a lot of genetic data. Of course, there are still a lot of issues like reimbursement and so forth, but basically the technology is allowing for one to have his genome for a reasonable, more than reasonable price. Second bottleneck is, you take this huge amount of genomic information. It's 6 gigs, right? 6 gigs. So it's 3 from the father, 3 from the mother. And you have to find within this book of billions of nucleotides, of letters, you have to identify the one letter that is indeed might be affecting the individual throughout one's lifetime, like a BRCA1 mutation, or so forth. And that was the second bottleneck, which was, I think it's generally known as the bioinformatics. So how do you take all of this information and eventually make it available and quite visible to the healthcare provider? But then in 2016, we have learned that the narrowest bottleneck of all is that the mere number of genetic counselors worldwide. So back in those days, there was an official publication of the American College of Medical Genetics that estimated the number at 7,500 genetic counselors. Now I'm sitting here in this interview with you, and I'm telling you that genomics is going to be part of the life of everybody, that we have to use it for prevention medicine, we have to do it for precision medicine, and I'm also suggesting that the genome will be part of our medical record in the foreseeable future. And I also told you that the interest in genomics can be around reproductive health, around oncogenetics, and around pharmacogenomics. So how will 7,500 genetic counselors be able to support the global population of growing to 9 billion or even more individuals? How are they going to be able to give a genetic advice to every individual worldwide? If you just take numbers, then very approximate number, you have in North America, roughly 4,500 genetic counselors. So the majority of the genetic counselors are in North America. And you have here roughly 4.5 million live births per year. So only if you need to meet, which is recommended today, to meet a genetic counselor for pregnancy to explain what are the modalities, already here you have overwhelmed the capacity without speaking about any other clinical indication, 6 states that has to be taken care of. And then what that we have seen since 2017, we actually started in 2017, I would say. What we actually saw is that the gap between the genetic counselors and the number of genetic tests being suggested to people is not getting smaller. It is actually, the gap is becoming larger and larger and larger. So we have decided that the future of genetic counseling and genetic medicine must be assisted by technology, by digital health solutions. And this is where we have established Igentify, so that we can allow the digital tools that will allow each genetic counselor to supervise. So it's going to be under the supervision of 10 times more patients per week, 100 times more patients a week, in a very safe zone, in a very educational zone, in a very, I would say, the patients would be engaged into looking to what they have, because we are doing it using different methods, which we'll go to shortly. So Igentify is really about allowing the current staff to supervise more and more patients, and certainly take primarily the burden of the low-risk patients. It's very important to say this. In genetics, there is no risk. There is low risk, there is high risk, and there is at risk, right? So The patients who are at low risk, we now know from IRB studies, we now know from our production studies that people love to get the information from a computer. So it is still supervised by the genetic counselor, but the genetic counselor can now support many more patients. And the time of the genetic counselor can actually go to be more towards the high risk and at-risk patients. So it is all about augmenting genetic counseling, and it was a long path, but we now see the fruits that are growing very quite fast.
Yeah, I was kind of shocked in reading some of that material that you highlighted in terms of, you would think the prenatal genetic testing is just so common and accessible, but it's, as you were pointing out, it's oddly getting less so. And I think that's for I guess one of the earliest uses, I guess, of these technologies. That's a bit shocking, but
Yeah.
it's interesting to see the connection between these tools in terms of making it more accessible and sort of bringing the sort of the ease back to an area that is obviously please.
It's first about education.
Yeah.
It is first about explaining to the general public what are the genetic tests good for, and they alleviate some tension that might be around it, right? Because it's very true. People want to know what they're being tested for and what. And then it is about educating about what is the action that can be taken for this. And that is actually to allow, let's say, couples at the reproductive health period of their when they're making reproductive health decision, to make informed decisions about what they're doing. So it is about explaining to the individuals about like many things that we have learned throughout the course of evolution of medicine. And this is also an important one as well. It is important to understand, for example, that the carrier state for a cystic fibrosis is an individual who is completely healthy.
Yeah.
So many people are telling you, when you want to suggest preconception screening, they're saying, well, there's nothing like this in our family. We should not be doing this. Well, this is exactly the people we are looking for. Yeah. The ones who don't know about anything because they are carriers of a potential disease to their kids. So this is why it is about explaining this. And more than this, it's about assisting the medical community to be able to provide this demand, because the demand is quite big, and in a safe environment in which they know that patients are receiving the right information. And also, of course, technology will tend to make it all in prices that are much more affordable and approachable for both the healthcare providers and the end user who are the patients who are seeking for this advice. So I would say that it is about eliminating a lot of barriers, and this is why it is eventually an end-to-end solution that will allow the education of the patients, the interpretation of their data, and the return of results. And the return of results is being done in a very unique way. We are actually creating dynamic multimedia content for each individual, which means that the explanation will be in different languages. Okay. We can speak, for example, Spanish and English, so that is, of course, different. And then it will speak about the actual clinical information that was given by the patient. Yep. Why was the test that was suggested to be this one, and what is the meaning for this? And that is quite engaging to patients. Multimedia tends to be, of course, quite engaging, and we see a lot of excellent results, and we're really enjoying it. Yeah.
Let's dive a little bit more into that, because I think because there's three sort of core themes here, and I guess the first two go together in terms of the non-invasive prenatal screening and the expanded carrier screening. Okay, so growing up, right, non-invasive screening, aneuploidy, trisomy 21, we want to think about that. And then, I'm thinking about autosomal recessive stuff from back in the, okay, Tay-Sachs, we got to make sure. But nowadays, there's a lot of autosomal recessive and X-linked conditions, a very long list that I see. Obviously, aneuploidy is something that goes in many directions. Talk a little bit about, obviously these two go together, and talk a little bit about sort of what the output is for the average person, and in an era where we're learning about so many more of these conditions that existed just a few years ago, what that's all like.
So try to think first about the magnitude of the change. As you said, quite rightfully. I mean, Tay-Sachs was the first disease that was screened, for example, in many different communities. So then it would have been quite reasonable to sit down with a patient and explain about Tay-Sachs and speak about the genetics of Tay-Sachs per se.
Right.
And it was also possible for the providers, to receive the results, look to one page, look to the second page, and say, okay, this is negative, this is positive, this is both negatives. What does it mean? But now, indeed, as you're saying, we're speaking about screening hundreds of diseases. So it is simply impossible to make all of these calculations manually. And it is also impossible to explain about each disease which is being screened for. So there's a shift. You need to explain more about what is the reason for preconception screening. You need to allow the tools to accurately calculate the risk, and then you need to be able to explain it to patients. And so only the magnitude of the test that is being allowed, you just said it. It started with one, and it's now hundreds of tests, and that is only for preconception screening. And then there are more tests, different categories within the field of genomics. So during pregnancy, one can suggest non-invasive prenatal testing, which is not to identify a risk that might be inherited from the parents, but it is, for example, to identify trisomy 21 that have occurred in this specific pregnancy. And so as people learn more and more about it, and they know that they're being suggested to the blood test because you might identify, and then you can decide on the action, which you can decide to do nothing. It's all for the patients eventually. Mm-hmm. And that is quite important. Yep. But if you take it further to this, Ira, let's speak about something very, which is a very hot topic now, pharmacogenomics.
Yeah.
So now we know that there are some drugs that people will not respond to, that part of the people will not respond to. So there are some drugs that if you give it to somebody, he will have excellent result with them. Some, it would be for them like nothing, and some will have adverse reactions. So there is now growing discussions about how to make it, to give the right one so that it will be accurate dose, it will be the right drug for hypertension for this particular individual, and that will tend to yield better patient care, right? But will also have huge savings. Yeah. Many times you're speaking about the field of psychiatry in the context of pharmacogenomics, in which it takes months on months to identify whether there is a positive effect. But if it's a drug that to start with, it will not have an effect on this given individual because of the genomic background, then why to try it? Right. That has been shown repeatedly to reduce hospitalization days, that is shown to reduce cost, and again, most importantly, to eventually have better patient care. Yep. And that's what we are here. So I would say that the examples are huge and dramatic. I mean, we know that roughly 10% of breast and ovarian cancer are due to inherited risk. Yeah. Of usually people are calling it BRCA1 and BRCA2, but there are more genes. But let's just focus on BRCA1 and BRCA2. So if you allow an individual to understand that it is possible to identify such a risk, and such an identification will allow for actionable actions, which will be more MRIs of the breast, it will be more frequent checkups, and so forth and so forth, because we want to prevent, because remember, nobody is being born with the breast or ovarian cancer, only with the risk to it. Right. So that's something which is going to be quite important. But then equally important will be if you were screened for the test for BRCA1 and it's negative, will be to explain to the people who took to those who are taking the test that you should still follow up with mammographies, with checkups, and so forth, right? So we are not eliminating the risk. So there's a lot of education which is here, and we have found it quite appealing to the to the patients to be able to look to their multimedia explanation repeatedly, share it with people, and so forth. And that, I think, is part of the big education game that we are in.
Yeah, the pharmacogenomics piece of this is exceptional, and I think there's actually much more there for you. I just as a side story, I have a father-in-law right now that's been battling metastatic prostate cancer, and they sequenced the tumors, and the list we got was, I mean, it was exceptional. I don't know what 95% of these genes did, but they, isolate certain ones, and they're on specific therapies now. But then the question came back to the doctor is like, okay, now should we look at you or my wife and then our kids for all this stuff? So there's a lot more here that I think this leads into, that you're going to have to, as you continue to grow and mature the digital assistant, the questions are going to be coming from all different angles in this era where we're getting these reports that I consider myself somewhat educated in this stuff, but I don't know what and most of this stuff means and what direction to go in. So
we are sharing the same feeling, and I must tell you that some digital explanations might have to be towards the actual treating physician. Right? So that might actually be an explanation to the treating physician that for all of this big list, really, after a supervised approach in which all the different lines were, as you said, you are describing it in the best possible way. After each of these lines was revised by an expert, really focus with the patient on this one. And this is what you should probably say. So this is where, because you are right, these lists are sometimes not manageable. Absolutely right.
Doron, what's coming up next for the company as we get a little further into 2024? Obviously, there's a lot going on. I know that you have several partners that you connecting up with in terms of getting the digital assistant out there, but other things that are happening this year, conferences, presentations, other initiatives that we should know about in terms of where you're going to be in your travels, talks you're going to be giving, places that we can run into you and possibly meet you.
So naturally, Igentify is appearing in the major genetic counseling meetings, and there are quite a lot of them. So it might be specific for fertility clinics, or it might be the more general one of the ACMG, or it might be specific to the genetic counseling field. I'll be more than happy to share with you the list of conferences we are going to be there. Also, quite importantly, we are expecting that a few papers describing the solution and its utilities and how efficient it is are going to be released shortly from different journals. So the embargo date is not yet out, but hopefully will be so soon. And then it will be, of course, shown quite clearly about the advantages of using digital solutions within the field of genomics. This year, we are still going to be focusing about genomics application. So there is a lot of happening in the field of preconception screening, pharmacogenomics, and then we are going to take a larger and larger bite into oncogenomics. That is quite important. But the more important thing is that eventually we see digital solutions as something that is improving patient care. And I can tell you it from from a very personal, perspective. I lived completely okay, unfortunately, but I was not understanding how painful it is to patients to get their appointment 6 months from now.
Yeah.
It doesn't make sense.
Mm-hmm.
Now, I understand that computers can assist a lot of the process on the way and cut down the queues and bring us to a situation in which maybe we can even arrive to the first meeting with some results in our hands. There's no need to wait for me for this.
Yep.
And I think that now, I think that within the field of healthcare, digital solution for me are becoming really, really important for the future of patient care, and not only in genomics.
Mm-hmm.
So we have actually established a platform, and the platform can have utilities in other fields, because the basic formulation of the medical interview and the medical decision of what test should go next can be used in other fields of medicine. So I think that not this year again, but we are going to start looking next year deeper into non-genomics application,
Mm-hmm.
which I think that if solutions like Igentify will be more and more available, will be made more and more available, then we can help patients with delivering of messages that are, you just want to deliver a message about a new study to your 2,000 patients. How are you going to do it without digital solutions?
Right.
Right? So that's what I would say. So we are still currently dwelling on genomics, but we see a lot of future also outside of genomics.
And in the middle of expanded carrier screening and pharmacogenomics and oncogenomics and non-invasive prenatal screening and everything that we've been discussing, at some point, somebody drops a bag with hair from Ludwig von Beethoven on your desk, which leads to the Current Biology, April 24th, 2023 study, Genomics Analysis from the Hair of Ludwig von Beethoven, whose 200th anniversary of his death is coming up in a couple of years. And you discovered that while we couldn't find connections to his hearing loss or gastrointestinal complaints, that his liver disease was indeed caused by hepatitis B infection via really complex metagenomics work. How did this all come about? Tell us this little story, because it's pretty cool.
So it's again being very fortunate to be, of course, the hair was dropped on the desk of a few colleagues of mine, and we have this. It was a great example. As you can see, we are all very, very interested in our ancestry and the stories. And this particular case, of course, everybody knows about the composer. And importantly here, and I think it is actually written at the beginning of the abstract, the composer asked that about his disease will be made known. And then it starts with some good sense of curiosity, population genetics, some investigation, and then the actual genetic data. So first, there are a lot of hair locks that were people kept from the period. And naturally, the first thing that you have to do is, if all of these people are saying that these hair locks are related to this given individual, no matter if it's Beethoven or anyone else, then first you have to say, okay, is whether people are coming to me with 5 different hairs and 9 different hairs. First, we have to prove that they are really related to each other. That is not just a story. So what better can be genomics than this? Because right, you are able to actually clarify if these hairs are of the same individual. And then naturally, if there are 5 different people coming saying these are the hair log that we have kept from Beethoven for 200 years, now you can believe them because 5 of them are saying the same story. They are independent of each other. And indeed, the genetic analysis is showing that this is the same individual. Naturally, the genetic analysis is not saying the name of the individual, but because all of them say the same story, then now you have a very good basics to understand what's going on. And then we know that, and now we're becoming even more curious because we want to shed light on these great composers that have affected the life of all of us. And we want to say, we know that he had some medical issues throughout his lifetime. And we know that now some of the diseases that we didn't know 200 years ago, we didn't know about genes 200 years ago. Yep. Maybe we can have some clues to what they were. So, for example, we know that a lot of the deafness is inherited. Is genetic but we couldn't prove it here. Right. But then there are we know that there was a severe liver disease, and then there was some findings that have suggested high risk for a liver disease that are certainly today well known. And that is, of course, coming to shed some of a light. Yeah. We don't know everything, but it's a very nice example of where genetics went and how genomics and population genetics that have been quite at the level of populations, how these principles are eventually being taken into the genealogy of a very given individual that that has done great things for humanity. So I think that that was the story. Naturally, there was also some attempts to find the right lineage and so forth, which were not successful. And there's a suggestion in the paper for this, in the article for this. But it was, again, and that is the basic. There are so many genealogists, and all of them are gaining so much from learning their family trees and from the ability to connect individuals that they were not sure that they are. And eventually that is leading to the ultimate message for population genetics, and it is quite clear we are all related. Yep. We go back again 200,000 years. We all have the same mother, and it is just that we are branches within the same big family. As the Y chromosome, of course, date shorter, but that's okay. It's different molecules, and I think that eventually this particular information or study was about using population genetic principles and genomic knowledge to both assess validity of the claim for hair lock of the same individual, and then to shed some light about the ancestry and the diseases that might have affected him throughout one's lifetime, throughout his lifetime. Yeah. And it was really interesting, I must say.
Yeah. It's extremely cool work, and like a genetic time machine in many ways, right? I mean, a unique view on the past that, as you're mentioning, we with these tools we now have the ability. It's awesome work. I love the whole story. I love reading everything about what you've done and where you're headed with this. So I'm rooting you on, and as you continue to grow this company and keep the technologies out there and into a broader array of labs and clinicians, and just going to continue to follow you and everything you're up to, and rooting you on. Again, for everybody that is going to be listening to this particular episode of our show across the various podcast networks, or watching on our YouTube channel, again, you've been spending time with Dr. Doron Behar, Chief Executive Officer and founder of Igentify, doing really amazing things to advance these genomic medical services to more clinicians, more laboratories, and more patients around the world. Doron, I really want to thank you for taking the time out to talk about your story, what you've been doing, everything you're up to with the company. Thank you for what you do, and as we like to say on our show here, thanks for helping to create a better tomorrow for millions of people out there via what you're doing and via the creation of these tools. It's a really great story, and I'm going to continue to follow you.
Really. Thank you, Ira, and really many thanks for all the followers and the one that will listen. Eventually, what that you're doing is the essence of genomics and digital. This is part of the education. You can help to grow the attention. So thank you very much again.
We look forward to spreading the story. So really great having you, Doron.
Thank you.